Is this working? Wow, that was magic. Yeah, just echoing what everyone else has said. I'm really grateful to be able to have the opportunity to come talk to you guys today. I am a complex care doctor for Joey, Melissa's son, who has the ACTA2 mutation, and was hoping to just spend a few minutes elaborating on what Dr. Carroll was saying earlier about your person and the importance of having your healthcare team on your child's side in multiple areas of care. And Melissa and I are gonna just tag team this. So this is Joey. For people who might not know him, he is 17, and this is my disclosure that I really don't have any expertise at all to be able to be standing up here. Joey is 100% of my expertise, and I'm really blessed to be able to take care of him and kids like him. So why does complex care matter? Why should you care about it? Why should you want one of me? I think this quote just sums it up, that when you think about your child as an individual, it's really hard to advocate for them. It's hard for other people to understand why devote all of these resources to this one patient or an ultra rare disease. But when taken together, we are an ocean, and it's important to kind of change the mindset or the framing of your child's care team to be able to think about your child in that way. So what is this? I am a general pediatrician by training. I did not do a fellowship. I did not do any extra training to be able to do what I do. Complex care is a pretty new field within pediatric medicine. It's not a boarded specialty. It's a really mixed bag of providers right now. I happen to go to a training program that gave me a lot of access to kids with multiple chronic conditions and ultra rare disorders. And so I usually tell families that my expertise is time. My clinic visits are an hour and a half, and I have 8 patients a week at most. So whereas a general pediatrician, your regular pediatrician probably gets maybe 30 minutes if you're lucky to spend time with your child and kind of go through everything, I have plenty of time to talk about some things that don't usually get to be brought up in primary care visits. So we know that for hospitals that have complex care as a specialty there, your length of stay is decreased by about 40%. We have time to talk about resources and insurance and medical equipment needs and sort of all of the other things that are involved with taking care of a child with a rare disease that really go beyond the scope of what a general pediatrician is able to do in a 10 or 15-minute visit. This is just a diagram of my own program in Wisconsin. So just to kind of think about kids with a lot of different common pediatric illnesses that get a lot of money and a lot of research funding and a lot of grant funding. And it's kind of hard to think about ultra rare disease in that context because the population is never going to be as big as the population of, let's say, sickle cell or cystic fibrosis, some of the more common pediatric chronic conditions. But I think we do a disservice kind of thinking about ultra rare syndromes and diseases in silos. And so my expertise really comes from taking care of 60 ultra rare disease patients that are all different and trying to think, how can we advocate for this group as a whole? How is this group alike? How are the services that they need alike? And so I think kind of starting to think about how is your kid similar to not only other kids with ACTA2, but other kids with other rare diseases? And can we kind of group together as a bigger group to do some of the things like advocacy and protocol development and talk about what you need in your electronic medical record and some of that kind of things. There are different models of complex care in different systems. What I use is something called a tertiary care, primary care partnership model or consultative model, which is where I essentially function like a specialist. I'm a consult service on the inpatient side. So I round on all of my patients when they're in the hospital and kind of help to provide this background and context for patients. And then I also get to see kids in clinic, which I think is really important to have somebody that is with you and being involved with your child over the various aspects or continuity of care. So yeah, as I mentioned, we are a primary care, tertiary care partnership model. It's a mouthful. We work with other pediatricians in the community and with all of the specialists. So whenever Joey has a visit with his cardiologist or his pulmonary doctor or his GI doctor, I show up, I listen, I provide feedback, I help with Joey's history for the parts that Melissa can't remember in a 2-second snippet. And I'm there to listen to the plan. I have input on the plan and I just follow him around essentially. And I think that's really valuable because then when Joey's in the hospital, I can say, oh, he had this gastro visit 2 weeks ago and their note's not done yet, or we haven't gotten the med yet, but this is the plan, and kind of carry out Joey's care across different environments. And yeah, my particular program is the only money-making program in the country. So we have a relationship with Wisconsin Medicaid that pays me per member per month to do what I do, which is great. Because most complex care programs, if you have the support of your hospital, the hospital kind of has to just accept the loss. But if you want to take my model back to your hospital, happy to share it because it's been really beneficial for our patients. And we've been able to prove to Medicaid that we do improve care of kids with ultra rare disorders by having me around. So now we're going to sort of go through 3 things or recommendations, things that I consider especially unique pieces of what I do. The first one is what I call creating a care philosophy. So when I sit down with a patient or when I met Melissa for a first time, it's just an acknowledgement that every caregiver wants something different for their kid. Every caregiver goes about that in a different way. And it's really important that Melissa is not carrying that burden around of sharing like her whole philosophy, the way that she thinks about everything with every person, because that's really emotionally draining to have to sort of bare your soul and talk about big questions like goals of care and how do you want to communicate with providers. It's so hard to have to just repeat all of that over and over again. So I really make it a point to talk to families about that when I meet them, spend a long time talking about what's your threshold for coming into the hospital? What are you willing to do at home before you get overwhelmed? How does the rest of your family react to your kid being in the hospital? Are there supports that you need in the hospital that might be unique or tailorable to your kids? Like, do I need to bring you knitting every time Joey has a procedure? Because I will do that. And so we spent a long time talking, and these are the 3 things that I sort of came out of my conversation with Melissa about.
I think for me, when we met was when Joey had his big boobs in 2020. And it was at a very difficult time because he had just coded, things weren't going well. And we had to come up with frank discussions. How far was I willing to go? What was I willing to do? You know, so it was a lot of discussions. And over time, we've had discussions of what do I want for him? You know, and we've drawn that line. Where, at what line do we stop? And I think that's where it kind of helps, because also on paper that I passed around is her care coordination notes. Also, when we meet new people on paper, we had a specific doctor like, who the hell does she think she is? because I'm like, no, I don't want this, but I'm willing to do this. And it's a good collaboration because because Joey's so involved with every system, they diagnosed him with Crohn's. And I said, and they wanted to treat him right away. And I'm like, no, we're not, because we need to take a step back and focus on, if we treat him, what's it going to do to his heart? What's it going to do to his lungs? And I want to make sure that everything we don't sacrifice something else to help something else. And I think that's where she came in. So when we were finally able to meet the GI doctor, and he was like, literally, who the hell she think she is, telling me what I am or not going to do. And then it was like, no, he's really with it, because on paper, you would think he's a vegetable. But he talks, he plays video games, and he's obnoxious, and he'd make a great serial killer if he was able to walk. But the point being is, it's nice to have somebody in your corner that can manage all the different specialties and get them talking. Because that's where a lot of us, when we have 15 different specialists, we have that disconnect, because not every time does cardiology speak with GI, which in some ways they kind of relate, or pulmonary and cardiology, where we one time had cardiology, the thoracic surgeon, and pulmonary arguing that, no, it's not mine. No, it's not mine. And finally I agreed that we're just doing the surgery prophylactically to give him a better quality of life. And when he actually went in, he was like, holy cow, I'm glad I did the surgery. So it's kind of interesting to have somebody in your corner that can behind the scenes advocate, because really, I don't have 140 hours a week to keep Joey going. And that's where she has really stepped up and made the difference. And it's really important to have that thorough care, or, like the care coordination summary that we have, and keep it updated, because it does give that history or chronological order of this happened then, this failed then, and it just keeps going. So it really is vital for Joey. And I can say undoubtedly, emphatically, if Jessie hadn't come into the picture, we would not be standing here having this conversation, because we are able to do things that nobody does, because we have gone to the palliative side. So I can do stuff that normally nobody would ever do. So I'm lucky that way.
Yeah. And one of Melissa's top priorities, as you see here, is to keep Joey at home as much as we can, because that's really important to his quality of life. And so, like she said, I think knowing that about a family really gives me the chance to kind of open up my creative mind and do some of the more artful sides of medicine and say, I don't know if this is going to work, but it has a good chance of keeping him at home for longer. As long as we have this mutual understanding that it might not work, let's try it, which I think is just really important, because everyone eventually gets to the end of everyone's knowledge, right? Your kid is eventually going to get to this place where your doctors don't have any more ideas. And to be able to have the ability to think out of the box and try something that nobody's ever tried before when you get to that point is really important. So this next slide is going to give one example of how we were able to think out of the box for Joey. Just a trigger warning, it's a graphic slide. Okay, so as Melissa mentioned, Joey's oops, it was an episode a couple of months before COVID started, where he had a small bowel obstruction and a lot of his bowel died, and he needed an ileostomy, which is where we take the small bowel and attach it to the surface of the skin so it can drain, because he didn't have enough bowel to connect it to his bottom anymore. And as no one anticipated, his ileostomy stoma died. So we require a lot of healthy vascularized tissue in the bowel to be able to create this nice hole and surface to the skin that you can put a nice little bag or a pouch around to catch the stool. And that didn't work for Joey. It died after about a week. The surgeon was like, I'm not sure that it's a good idea to open him back up again. And if we resite this, put it in a different spot, there's a really good chance that this is going to happen again. And so we just need to figure out how to make this work. And so this picture on your left is what Joey's ileostomy site looked like not too far out from surgery. He had bilious output draining just onto his abdomen because we couldn't figure out a good way to collect the fluid because of his connective tissue disease. None of the pouches would adhere or stay on very well. And so Melissa and I went to the surgeon and, we said, there's got to be something we can do. He's on pain medicines around the clock. This is burning his skin. We tried every cream in the book. We tried courses of IV prednisone, high dose, every anti-inflammatory that exists, and nothing was working. And so, I have the audacity to ask them really potentially dumb questions, one of which, can we just take his whole bowel out? So the answer to that was no. But then my next question was, can we put a tube in it? And the surgeon was like, well, no, his peristalsis will just push the tube out. The tube won't stay in. And I was like, yeah, that's true for normal physiology, but Joey doesn't have peristalsis. His bowel is not working anymore. So can we try it and see if the tube will stay in? And so she agreed. And now Joey has a Michelin G tube in his ileostomy site. His skin looks much better. Melissa can change the tube at home. We get tubes from the DME company delivered every month. He really doesn't have to come into the hospital at all for this anymore. And that we were only able to do that because I'd had this understanding with Melissa that we're okay to try something new that may or may not work. There's a potential that we could have punctured his bowel putting the tube in, and we talked about that risk, and it had to be better than, there had to be something to make it better than the way things were. And so that's kind of just one example of us thinking out of the box.
And to preface this, we first tried a Mickey button, and that was a colossal fail. Because the hole wasn't big enough and everything. Also with it, when we did it, his hole was so tiny, they had to stretch it. So the ileostomy out was so tiny, it was like they had to keep stretching it. And it took like probably 15 minutes of stretching to even get a peg tube in. And then we tried a 14 and it still was clogging. So then I think we're up to an 18 French, but we also have it, we had it hooked to a ferro bag, and that was an epic fail because the ferro bag was too small. The tubing was too small and too long. So then we were like, what, we had it draining into a diaper. That was bad because he had so much output because of all the fluid that we give him. So then we went to a Uracell bag. And so a Uracell bag, so we have a Uracell bag for his stomach because he doesn't have any forward motility. So we have that draining to that, and we have a Uracell bag attached to the right side. So we have double Uracell bags. So it was kind of like the transition, the process of it was kind of interesting.
Yeah. So, a lot of trial and error, a lot of just convincing everybody to try something and then huddling about why it didn't work and what might work better.
Well, and to top it off, so when they did the surgery, closing him up from the surgery, his tissue just basically shredded. Every time they would stitch, it would shred. So they actually mismatched layers of the fascia to even get it closed. And then it was even questionable if it would even stay closed. And then the whole midline incision from the surgery was necrotic. So he lost all his tissue midline as well. So it was a process. His belly button fell off. That was the only good thing about it. It was a fake belly button.
So that was definitely a lesson learned too, is thinking about open surgery or major surgery in these kids, doing it before their disease progression gets to a point that they're impossible to close, which is what happened. Joy has had multiple surgeries on his abdomen, but the one that he needed the most was the one where his skin just fell apart. And yeah, that contributed to this too. I don't know if this would have happened if he'd done it when he was younger, but clearly at the point that he needed it, his tissue wasn't healthy anymore. Okay, getting off the picture, sorry guys. Okay, and then the last thing is just the importance of a cheat sheet, which a couple of people have alluded to, and Melissa brought some copies to pass around. So these are the things that for my patients go in the top of their chart at the front page of their medical record, no matter where they are. This care coordination note pops up, is what we call it. And things to put in it. What do you want everybody to know about your child? If your child needed to go somewhere else and you had to give like a one-pager to a different doctor, what really needs to be on there? Are there things that have worked? Are there things that we thought would work or should work that didn't? And then what are sort of your child's discharge criteria? A lot of times it's different for a parent that runs an ICU out of their home. When are we getting to the point where the hospital is not any different than home? And that's different for everybody, but it's really important to communicate, because we don't need to treat all kids the same. Never, and especially not in a kid with a rare disease. So this is Joey's cheat sheet. It's really long. You don't have to read the whole thing, but just wanted to show the categories that we use. So we have a one-liner. We have some baseline abnormal physical findings, abnormal labs, abnormal vital signs, and baseline function. So I tell people to read this paragraph anytime a new person meets Joey, because a lot of times our kids' baseline function doesn't match what their chart says it should be. Like Melissa said, Joey plays video games all day. He sits up, he has a great quality of life, he laughs, he chats with friends on the video games. And looking at his chart for a kid that is ventilator dependent, TPN dependent, has had a heart surgery, has bad white matter disease, no doctor is going to picture the Joey that exists. So how do we interrupt that? And what can I share about things that Joey loves? And then location considerations. So there's a section for when they needed to go for imaging or anesthesia. There's a section for what floor to admit him to, inpatient considerations that might be unique to Joey, and then a whole section for perioperative stuff that everyone can see. And then we've worked with a lot of the specialists in our hospital to create well and sick plans and kind of think about this idea of anticipatory guidance for our kids. And then we use that and put it all in one place. So for Joey, for each one of his specialties, we sort of have this list of things that work or don't work, or that happen or don't happen. And this is all in one place so that it comes up at the beginning of a kid's chart. And if you're in the emergency room, it's just like this quick, what do I need to know to take care of this patient? And yeah, ending with Joey. So thank you guys. Melissa did bring some copies of my notes, which every kid is different, but just for if anyone wants to be able to read through it or take it back to your own person, whoever that might be, or yeah, I'm happy to help.
And we can also email a blank template with the different headings and subcategories. So that way you have something to kind of go off of to make it easier versus reinventing the wheel.
Cool. Thanks, guys.